Last time we discussed heart failure, and this time around we're going to be discussing myocardial infarction. But just to be sure that we really understood what heart failure is, we are going to be doing a couple of questions, about 5 of them, from the link that I provided. If you're watching this from TikTok, you probably missed the link because if you didn't go to YouTube after I said you go to YouTube, and do that quiz, these are the type of questions that are there, and you're going to revise them together. And credits to Sarah Aren, because this QBank is actually hers, and I found it to be really super duper helpful. So the question reads, which of the following are not typical signs and symptoms of right-sided heart failure? It's a SATA question. Select all that apply. So A, jugular vein distension, B, persistent cough, C, weight gain, D, crackle, nocturia, and orthopnea. Okay, remember we said that the acronym for answering this question right is swelling, and if that is said and done, then A, that is jugular venous distension, would actually be right. Just look at the on your left part of the screen so that you understand what I'm talking about. We will have weight gain as right, and we are going to have nocturia as right. Orthopnea, crackles, and persistent cough are all significant with left-sided heart failure. Please do not forget that. Do not forget that. And, just go and look into it again. True or false? Patients with left-sided diastolic dysfunction heart failure usually have a normal ejection fraction. What do you think about that question? Is it true? Is it false? Is that statement correct? Is it incorrect? And the answer is actually true. They have a normal ejection fraction, but with the right-sided diastolic dysfunction, then the ejection fraction is actually lower than 50. Which of the following tests/procedures are not used to diagnose heart failure? A, echocardiogram, B, BNP, C, nuclear stress test, and D, Holter monitoring. Remember, echo is going to be definitely useful. BNP, we talked about this. We said it's a blood test that is actually used to diagnose heart failure. High levels of it is highly suggestive that this heart failure or any heart condition. Nuclear stress test is also paramount. Well, but the Holter monitoring, this will not help us diagnose heart failure. This is actually useful in diagnosing heart rhythms. And these are just heart rhythms like, super ventricular tachycardia, atrial flutter, and atrial fibrillation. A patient taking digoxin is experiencing severe bradycardia, nausea, and vomiting. A draw lab shows that the digoxin level is 4. What medication do you anticipate the physician to order for this patient? Do you expect anacarin, aminophylline, digibind? No medication, because this is normal digoxin level. Normal digoxin levels are 0.5 to 2 nanograms per milliliter, so definitely D becomes wrong by default. And as you can see, this patient is actually showing that they are having an overdose of digoxin, like the levels are so high, that is why it is 4. So we're not going to be giving this patient anacan or aminophylline. We are definitely going to be giving the antidote, which is digiband, and C becomes the only right answer. What type of heart failure does this statement describe? The ventricle is unable to properly fill with blood because it is too stiff. Therefore, blood backs up into the lungs, causing the patient to experience shortness of breath. Left ventricular systolic dysfunction, left ventricular right-sided dysfunction. What is that? Right ventricular diastolic dysfunction, left ventricular diastolic dysfunction. And the only right answer, it is actually too direct, is D. Okay, because we said that the heart is usually too stiff in the left ventricular diastolic dysfunction, and then in the left ventricular systolic dysfunction, the heart is too weak to squeeze normal amounts of blood out of the heart. I honestly do not know what B and C are. Okay, so definitely the answer is D. So if you got less than 3 out of 5 in that QBank that we just had, please go back and look into heart failure again and try to see where it went wrong. It's about 19 questions. It's a good choice of sets of questions. Please do it, okay? So right on to MI, that is myocardial infarction. And just by definition, what do you think myocardial infarction is? So let's separate the terms again, okay? So myocardial Myo is a muscle, just from the muscle. Cardio is the heart, and then infarction is death of a tissue. Okay, so we are talking about the heart, the muscle part of the heart dying. Okay, so just by definition, MI is blockage of the blood flow to the heart, and this is usually caused by a blood clot, and this subsequently leads to that muscle death, the muscle part of the heart dying. All right, so let's dive into the causes. And the most common cause, definitely, this just it, is coronary artery disease. We're going to be talking about this in the coming video, so be on the lookout for that. And again, we're talking about coronary artery dissection, and this is very common in women. And again, coronary artery spasm, this is caused by conditions such as hypertension. And in people that use cocaine, they're usually mostly likely to experience the spasms as well. Then we have embolism, and finally coronary hypertrophy. So let's just dive right into types of myocardial infarction. Type 1 is myocardial infarction that is spontaneous. Just I have outlined on the side, you just look at it. All right, and then the second one is MI secondary to ischemic imbalance, and then type 3 is MI resulting in death without biomarkers. Well, in type 4 we have 4A and 4B, where 4A is related to PCI, and PCI is percutaneous coronary, and then 4B is related to stent thrombosis. While in type 5 we have MI related to coronary artery bypass grafting. This is CABG. This is a term we're going to revisit way later. I think the telltale sign of myocardial infarction is chest pain that is severe. It is stabbing, it is crushing, and well, more often than not, this pain is accompanied by nausea. It is accompanied by vomiting. They have shortness of breath and low-grade fever. Subsequently, this might lead to cardiogenic shock, and we have cardiac dysarrhythmias as well. Let's dive into diagnosis, and mostly this is through the cardiac biomarkers, which are also the enzymes. And unfortunately, it is not all these enzymes that just because they're present indicate that the heart is having an infarction, or the heart is actually dying. So the only cardiac specific enzyme is troponin 1, which peaks 4 to 12 hours up to 3 weeks. Other books or studies say it's 10 to 14 days. I will have to write that here so that you can actually look into these onset, peak, and duration, and be able to understand it better. Okay, so the next exam I'm going to be talking about is usually the first one to be released, and that is myoglobin. I ever saw that question somewhere and I was like, it's troponin. No, the answer is myoglobin. Why? Because it rises in the first 1 hour, peaks in the first in 4 to 6 hours, and then it falls back again into normal ranges in the first 24 hours. Well, CK, creatine kinase is usually released within the first 3 to 6 hours, and it peaks at 18 hours. Well, the other enzyme is CKMB. The onset, duration, and peak times tend to mostly be the same as CK. The peak is 18 to 24 hours, yeah, but well, it tends to disappear from their bloodstream more sooner than CK. Another blood test would be WBCs. They tend to be elevated in the first 2 days, and then they go back to normal after a week. But clearly, WBCs, white blood cells, cannot be definitive in identifying heart failure. Anything can cause WBCs to be elevated. Okay, even if there's like a system here. So let's go to ECG. That is your favorite of everybody. ECG, we're expecting non-STEMI and STEMI. I'm going to show you the strips right here, and then with time we can actually look into these things, these ECG things, as a topic by itself way later. So this is STEMI and this is non-STEMI. Now, what are the repercussions of this ECG? What does non-STEMI and STEMI mean? In non-STEMI, we do not have ST elevation, right? And it is not as bad as STEMI, where there is ST elevation, okay? Because in STEMI, we have total blockage. That means the heart is already dying as we speak. Once you see those the ST elevated, the heart is already in crisis. But in non-STEMI, there's just maybe a blood vessel is just blocked and nothing serious is happening to the heart as we speak. I hope we're okay up to that point. And this is an ECG of a STEMI. And just for reference, I'll put them two here: STEMI, non-STEMI, and a normal ECG, so you can actually see the difference between this normal ECG here and these other ECGs, okay? So at this point, we're going to dive into the management of myocardial infarction. And remember the aim at this point, the main aim is to remove the clot. We talked about a clot being in a blood vessel, and this clot is hindering blood from flowing into the area where it's supposed to be, that is in the muscle of the heart, okay? So there are ways to do this. I'm going to start with the medical management and then I'm going to the surgical management. The medical management, I'm going to start with the thrombolytics, and I'm going to be talking about TPA, that is tissue plasminogen activator. It's commonly used. An example of this is streptokinase, atteplase, and we administer this drug in the first 3 hours. And remember, we cannot administer this drug if the patient is over 80 years, and if the BPs of this patient are 180 over 110, then you do not administer this drug, okay? The other drug that we are going to be talking about is those that prevent the clot from forming, and this is usually aspirin. We're talking about heparin. We are talking about aspirin, clopidogrel. Clopidogrel is actually more advised or more advocated to give. Well, most people are actually giving aspirin. I don't know why, but well, there's that. We are also keen on administering nitroglycerin. This widens the coronary vessels. But we have to be keen with the BPs as well, okay? We also talking about oxygen, of course. We need to administer oxygen, right? It's just common sense. We have to administer oxygen. Then also we have to give beta blockers. Give me an example of beta blocker. Do you remember of a beta blocker? Do you remember any beta blocker right now? Any beta blocker? No? So your beta blockers are the roles, yeah, like carvedilol, bisoprolol, those kind of drugs. And then we're going to be giving, we are keen on administering ACE inhibitors. And a good example would be, those are your prils, okay? Enalapril. Enalapril is a good example of an ACE inhibitor. And then we are keen on administering statins. And an example of a statin is mostly given at night to lower lipid levels. Atorvastatin, you got it right. So we are keen on doing that, and of course, because of this pain, we are also keen on giving pain meds, and morphine, the drug of choice for this pain is IV diamorphine, 2.5 milligrams to 5 milligrams intravenously, okay? We have to take care of that pain. It's so severe. Remember, we said it's crushing. It is severe. Now, after you give these drugs, especially TPA, this is really very, we are very keen on TPA thrombolytics. If you give these drugs, we are keen on these things. You do not want to be giving injections anyhow. You do not want to be giving IM injections. And we are going for compressible IV sites, PICC, because of the risk of bleeding, okay? Remember, this increases the risk of bleeding, so we are avoiding as much to just keep on pricking these patients. For the surgeries, we are going to be looking at angioplasty and CABG, that is coronary artery bypass grafting. And this is actually a curative surgery, something like that, but it can actually predispose one into getting MI, because remember that in type 5 of MI, it is related to CABG. Okay, preparations for this surgery: NPO 6 to 12 hours, and post surgery we are telling these patients to avoid heavy lifting. There you go. I'll list the complications on this slide. We can go and look into them more keenly, and as usual I am going to attach a link on the YouTube video. So if you're watching this from TikTok, you have to go to YouTube and do this quiz, and I'll choose 5 questions that we will start with before we do CAD next time, that is coronary artery disease. So be keen, be vigilant, go and look at it. The questions that you go wrong on, just go and study, and if you have any questions, be keen to ask me, and I'm hoping to see you in my next video. Goodbye.